Good afternoon, everyone. Welcome to today's 34th ECHO session. Today we'll be looking at a topic which is addressing missed opportunities in the National PMTCT Cascade. My name is Dr. Kandiwo. I am going to be your facilitator. And we have our didactic presenter, and that's Dr. Keith Mweebo. I'll give him a chance to introduce himself further. But in the hub, we also have a few subject matter experts, and that includes Dr. Mweebo, Dr. Mtsangwa, and Godfrey. So I'll just urge you all to freely participate. We want to be able to interact with everyone who has joined in today. So before we proceed, I'll just give a brief recap on what we discussed last week. Last week, we were looking at cervical cancer screening, and we discussed the various prevention measures that we can put in place. We also discussed the importance of encouraging our women living with HIV to get screened for cervical cancer. So I'll ask Nomsa to give us a bit more details regarding what we discussed last week. So Nomsa.
Good afternoon, everyone. My name is Nomsa, and I'm just going to give a very brief recap of last week's topic. So last week we had cervical cancer prevention program, and the presenter was Dr. Kelly Luveya. So we learned that cervical cancer, particularly invasive cervical cancer, is one of the commonest malignancies worldwide, and that in Zambia as well, cervical cancer is the most common cancer. And it's actually the most frequent cause of cancer-related deaths. And that in Zambia, we have embarked on a comprehensive control of cervical cancer. And this is a national program that is government-owned. But we also learned that women living with HIV are at high risk of cervical cancer. But the news is that cervical cancer is preventable, and that it also requires a comprehensive preventive approach. And one of the strategies that Zambia is embarking on is vaccination, particularly HPV vaccine for adolescents. And that we also learned that cervical cancer needs to be integrated with ART programs. And I think in a nutshell, that is a recap for last week's session.
Thank you very much, Nomsa, for that recap. We'll be going into our didactic presentation. I'll just want to quickly remind everyone to just kindly mute your microphones, and let's pay attention, because this is a very interesting topic, so we could learn one or two things. So, Dr. Keith, perhaps you could just briefly introduce yourself as we are going to share your slides.
Good afternoon, everyone. My name is Dr. Mweebo Keith, Public Health Specialist, PMTCT and Adult ART from CDC-Zambia. And welcome to today's presentation.
Okay. Okay. So you can tell us perhaps a bit more regarding the scope of your work with regards to PMTCT?
So I work with PEPFAR programming, where we support facilities, Ministry of Health facilities, with regards to optimizing opportunities for prevention of mother-to-child transmission. That is in the area of PMTCT. Then in adult ART, we provide support for the whole cascade, from case identification, patient monitoring, as well as monitoring of standard of care. So looking forward to our discussion today, where we focus on addressing missed opportunities in the PMTCT cascade.
Okay, thank you very much. So I guess we can go straight into the presentation.
So at the end of this discussion, we hope all participants will understand how to eliminate leaks in the maternal PMTCT cascade. The second objective is to understand steps to eliminate leaks along the HIV Exposed Infant cascade as well as have a good understanding of utilizing cohort monitoring as a tool for monitoring HIV exposed infants retention, and then determining actual MTC rates that are very important and key for elimination of mother-to-child transmission as outlined by World Health Organization. So in this presentation, we are going to use a bit of language that is very common in PEPFAR programming. So I thought I could include a bit of definitions so that we are speaking the same when we use these abbreviations. So ANC refers to antenatal care, PMTCT, prevention of mother-to-child transmission of HIV, HEI refers to HIV exposed infants, PMTCT stat. This is the number of pregnant women with non-HIV status and antenatal care. PMTCT ART refers to number of HIV positive pregnant women who received ART to reduce the risk of mother-to-child transmission during pregnancy. PMTCT EID refers to the number of infants born to HIV positive women who received a first virological HIV test. And in PEPFAR, we refer to sample collected. This is slightly different to HMIS, where the ministry refers to a result that has arrived back. But for PEPFAR, we report a sample collected by 12 months of age. And then PMTCT HI pause refers to number of HIV-infected infants identified in the reporting period whose diagnostic samples was collected by the age of 12 months. PMTCT FO, percentage of final outcomes among HIV-exposed infants registered in the birth cohort.
Okay, so before we proceed with the presentation, we have a few questions that we're going to ask. We'll start with our first question. And the question reads, which of the disaggregates listed below is included in the numerator when reporting the number of pregnant women with non-HIV status at first antenatal care? So is it A, non-HIV positive at entry, or B, newly tested HIV negative, or is it C, newly tested HIV positive, or could it be all of the above? So I'm going to launch the first poll question, and we can take a few seconds to choose one answer. Is it A, B, C, or D? You can keep voting. So far, less than 50% of the facilities and participants have responded. What do we think? So we'll keep running the poll for a couple more seconds. We are only at 50%. We want to hear from you, our participants. Okay, I'm going to end the poll now, and we'll discuss the answers at the end. Okay, continue.
Okay, moving on to the PMTCT Maternal Cascade. So ideally, we start with the expected pregnancies, and this is used to set the target. The particular formula we use in Zambia, which is 5.4% of the population, is based on a population model that was simulated in the early 80s by Central Statistics Office. We just wanted to indicate that because of changes in the population dynamics, that utilization of family planning and fertility rates, this formula is a bit outdated and tends to give you a higher target as what is obtaining on the ground. Then for PMTCT stat denominator, this is the total number of ANC attendees. So number of new ANC clients who present at ANC clinics is counted as the PMTC stat denominator. Next. So for PMTCT stat numerator, this is the number of pregnant women with non-HIV status at first antenatal care visit, and is composed of non-positives at entry. So if a woman presents and we have evidence that she's a non-positive, she is part of that PMTC stat. She is part of that disaggregation. Newly tested positive are part of that disaggregation. Newly tested negative are part of that disaggregation. There is also the last disaggregation, which is recent negative at entry. This is where in ANC, a woman presents with evidence that they were tested in the past 3 months. That one we could still take as a recent negative at entry. So we can see clearly that this indicator speaks to a person knowing their HIV status at the end of the interactions at ANC1. Either they are non-positives at entry, newly tested positive, newly tested negative, or they have a valid result which show that they were negative within the past 3 months. So that's the PMTCT stat numerator. PMTC stat pause speaks to non-positives and newly identified positives. So out of those that are attending ANC1, how many are positive? Either they are non-positives or newly tested positive. So in terms of PMTCT ART, this is number of pregnant women who received ART to reduce risk of mother-child transmission during pregnancy. So this includes non-positives who are already on ART at entry into ANC, non-positives at entry, and newly initiated on ART in MCH. So some of them are non-positive, but they are not on treatment. So they come in as non-positives already, then they are initiated on ART in MCH, as well as newly identified positives who are newly initiated on ART in MCH. So just to emphasize that only women initiated on ART prior to pregnancy or during pregnancy are counted under this indicator. So there is that issue of pregnancy, initiated during pregnancy or before pregnancy. This indicator does not count women who are initiated during the breastfeeding period. So here we have an example of the maternal cascade. This is how PEPFAR-supported sites performed as of end of March. Out of 295,141 women that attended in ANC at PEPFAR-supported sites, 97% knew their HIV status. That is, they were either non-positives at entry, newly tested negative, newly tested positive, or they had a valid document that they were negative within the past 3 months. Of that number, we see that 9% were either newly identified positive or non-positives. So the prevalence of that cohort was 9%. And that 9% yielded 27,000. That's for 2 quarters. And then linkage to treatment was 93%. So here we see a missed opportunity where 7% of positives were not initiated on ART. So when we look at the positive women, who are they? And this slide speaks to actual prevalence, including the non-positives as well as the new positives. we see that the majority above 25, that's where we have 13% in terms of prevalence. And then 20 to 24, 7%. Adolescents, the yield is at 2%. However, the next slide indicates that even if the volumes are lower for the adolescents and the younger women, we see that most of them are newly infected. So that's where the new infections are happening among adolescents. Whereas compared to the older women, majority of them are already known positives, and most of them present at ANC1 being on treatment. So the next slide just shows that when you look at under 20, more than 50% are newly identified, and a few are already coming as non-positive when we compare to the older women who are already non-positives at presentation for ANC1.
Okay, so we have our second polling question, which is in the form of a scenario. So you have 3 infants there. And we'll have a question that we'd like you to respond to. So there are 3 scenarios we have here. The infants are, the first one, you have a sample collected at birth with no result or record. And then a second sample collected at 7 weeks with a negative result. So this is in line with an HIV exposed infant. Then you have infant number 2. In this scenario, you have a sample that's collected at 10 weeks with a positive result in the register. And then you have a third infant. Sample is collected at 6 weeks, but you have no result. So what is the number of HIV exposed infants who got their first test from 0 to 2 months to be reported under PEPFAR? So from this scenario, I am going to launch our second poll question, and then we can have your opinion based on this scenario. So far, we only have 9 facilities and participants responding. I think we can do better than that. What do you think? How would you report these infants? The hub team, we can also try and pick one option. Okay, so we have a few responses. I'm going to end the poll now, and we'll continue the presentation. So Dr. Keith. You can continue.
Okay, so from the PMTCT cascade, now we move on to the Eid Cascade. So what we see in the program is that about 50% Eid testing at 0 to 2 months is only around 50%, and last quarter it was even below, but this quarter we are around 56%. So the question is, why low Eid coverage at 0 to 2 months? Next slide. So one of the reasons we see is that there is no system to check if all expected deliveries have presented for postnatal sepsis. So because the denominator we use is women who are on treatment, who present in ANC, who are positive, who present in ANC. So if we are not checking at the end of each month, women living with HIV who have delivered, then by the time we get to see exposed infants who are presenting and we are documenting them in the 0 to 23 months MCH register, which is a cohort, we have already lost some. So we don't have a system in place. However, we have seen some facilities that are doing very well on this indicator, and this is the table I'm sharing here, the innovation they have. They have a simple monthly activity sheet where they have the expected date of delivery, and then they can check whether this woman who is expected, for example, to deliver at the end of January has actually brought her baby in December for HIV testing in the 0 to 23 months integrated MCH register. So if the child has not presented at the facility, then community health workers can track and see what has happened to this child. And sometimes the answers they get are they have transferred out to another facility, they just came here to deliver, and they can document that. And that way we are able to account for all the expected HIV exposed infants by month. Next slide. So the other issue is suboptimal EPI EID integration. We see that immunization coverage is high for Zambia, but testing is still around 50 or below 50%. The register now is integrated, but what is missing is operationalizing this integration, because sometimes when people go out for immunization clinics at community posts, they are not able to do DBS. So we are advocating for inclusion of more staff at these posts so that even as they are immunizing, they can also ensure that they check children for exposure to HIV, and then they can do a DBS collection so that we don't miss on exposed infants who present within immunization clinics. The other reason is weak cohort monitoring and tracking of mother-infant pairs. Even where we have known that we have this exposed infant, but we don't track them as cohorts. So that way we are missing out on running an analysis of those who we had in April, babies born in April. How many actually we are retaining on the cohort are still coming to the facility to be tested, and how many have we lost? We'll speak more about cohort monitoring in the next few slides.
Okay, so we have our third polling question, and the question reads, a June 2018 HIV exposed cohort has 5 exposed infants. One of the HIV negative mothers who gave birth in June 2018 has tested HIV positive in January 2019. The midwife wants to add this child to the June 2018 cohort, but the MCH in charge wants the child added to the January 2019 cohort. So between the two, who do you think is right? So I'm going to call our third person, and we can give our opinion. So we have this June 2018 cohorts with 5 exposed infants. And one of the HIV negative mothers who gave birth in June 2018 has tested HIV positive in January 2019. So the midwife wants to add this child to the June 2018 cohorts, but the MCH in charge wants the child added to the January 2019 cohort. So between the two, who do we think is right? It's interesting that so far it's split almost 50-50. This is an interesting question, Dr. Keith.
Yeah, I can see the voting.
which cohort does this child belong to? Okay, I'm going to end the poll now. Looks like we are split, and we'll discuss the answers later.
Okay, so we'll start with defining what cohort monitoring is. So a cohort is defined as a population or group of individuals sharing a common event. So there are two key elements here. We have a population or a group of individuals, and then they are sharing a common event. So that's what a cohort is. So in terms of cohort monitoring, it is a tracking of a population in which membership is determined entirely by a shared event and whose members are followed over time in order to measure an outcome of interest. So rationale for PMTCT cohort monitoring. So why are we saying we should be monitoring exposed infants as cohorts? Because we want to measure mother-to-child transmission rates in line with EMTCT impact indicators. And here we are talking about case rate of less than 50 new pediatric infections per 100,000 live births. And final transmission rate that is less than 5%. So this 5% is WHO earmark for elimination. It's a benchmark. So when we reach below 5% as a country, then we are on track to achieve elimination. So PMTCT cohorts in Zambia. So HIV exposed infant birth cohort. So the purpose is to measure HIV-free survival of an HIV-exposed infant at 24 months and to initiate ART early in those that we identify as positive. So cohort outcomes can either be HIV positive, that's final transmission rate. We'll use that to determine the final transmission rate. It can also be HIV negative or unknown outcome. So unknown outcome means that at the point of exit, either the child is still breastfeeding or the child died before we determined the status of that child. So the primary source for this data is the integrated MCH Register 0 to 23 months, which is a cohort register. So requirements for cohort monitoring. So in this case, the population is HIV exposed infant. Shared event is the birth month. So the cohort here are HIV exposed infants. Then the shared event is the month the child was born. So not the month the child was tested HIV, but the month the child was born is what defines the cohort. And then we follow these kids over time. So testing time points is 6 weeks, although we take a test between 6 and 8 weeks, at 6 months, at 9 months, 12 months, 18 months, and 24 months. This is as documented in the Zambian guidelines. Then we want to also focus on retention. So what we mean by retention is if we had 12 HIV exposed infants in January, we follow them going forward 24 months up from now. How many do we still have? The desire is that we retain all the 24. And then we look at final outcome at 24 months, which can be the HIV status of the exposed infant, either positive, negative, or unknown. So cohort management. So each page in the register, 0 to 23 months, represents a cohort by birth month. So on that page, if we are saying this is April, we only put babies who were born in April. Then at the end of the month, space should be left for additions to the page for that particular cohort. And we say we have possible cohort additions. And these would be transfer-ins born in the same month and HIV exposed. They may be born at another facility. Then when they transfer in, we enter them to that page For example, if we had April, we enter them to the April cohort. Even when the time they are transferring, we are in December, we go back to that page when they were born. And then children born in the same month as non-exposed, whose mother has seroconvert later during breastfeeding period. So if a mother was negative, but then seroconverts later, say in December, and this child was born in April, we go back to that April cohort. That's why we leave space to enter them that cohort, because the cohort is defined by the month the child was born. So for this presentation, summary of key points. Testing at ANC is very good. As we saw in the presentation, 97% of women know their HIV status. But we have a challenge with the linkage to treatment where we are at 93%. So we need to close that gap. For PMTCT EID, this indicator reports the first sample collected for each HIV exposed infants under PEPFAR. However, the Ministry of Health reports a result. So this is where we have a difference. So once you collect a sample, if you are doing a PEPFAR report that child has tested. If you are doing MOH report, you wait until we get a result back. So we need triangulate expected deliveries for positive women and number of HIV exposed infants we enter in the integrated MCH register. Because what we are seeing is that even before we start the cohort, we have already lost some women. Some of them do not come to deliver at the facility, they deliver at home. So we need to check of those mothers living with HIV, how many have delivered? And then we check to see that their babies are actually accessing postnatal services and are registered in the cohort. All HIV exposed infants should be tracked as cohorts to ensure all have a documented final outcome. So we should also be wary of reporting. We shouldn't be reporting like we tested 10 babies in January. These 10 babies are coming from different cohorts. We should also be checking, going backwards and seeing month by month, those that were born in April, how many have had a test at 6 weeks? How many have had a test at 6 months? And we continue tracking them until we have a final outcome at 24 months. That way we will determine actual MTCT rates as opposed to cross-section where we just said we tested 10 babies and 5 were positive. Because in that number 10, babies are coming from different cohorts and we can't tell how many we have missed or how many are lost to follow-up. Thank you.
Thank you very much, Dr. Keith, for that presentation. Before we wrap up the presentation, we are going to relaunch our poll questions and we'll give our participants a chance to be able to vote again so we can see just how much we've grasped from today's presentation. So we'll start with the first question. Okay. So this time around, we're going to discuss the answers. So the first question reads, which of the disaggregates listed below is included in the numerator when reporting the number of pregnant women with non-HIV status at first antenatal care? So after the presentation, what do we think? Is it A, non-HIV positive at entry? Is it B, newly tested HIV negative? Is it C, newly tested HIV positive? Or is it all of the above? Okay, so just quickly end the poll and then we'll discuss the results. Dr. Keith, what's your comment on the results?
Yeah, so thank you very much. Yeah, looks like we have a big change compared to the answer we had before we went through the slide. And rightly so, the correct answer is D. So all those options are part of outcomes when we are testing mothers. So that indicator reports those who are non-positive at entry, newly tested HIV negative, and newly tested HIV positive. So the correct answer is all the above are part of the disaggregation.
Thank you very much. We are going to go on to the second polling question, which was a scenario. So we have 3 infants there. And infant 1, sample collected at birth with no result on record. And then a second sample collected at 7 weeks with a negative result. Then infant 2, sample collected at 10 weeks with a positive result in the register. And then the third infant, we have a sample collected at 6 weeks, but we don't have a result. So what is the number of HIV exposed infants who got their first test from 0 to 2 months to be reported under PEPFAR? I'm just going to rewatch the second question. I think Dr. Keith actually built on this one. Okay, there we go. So what do we think? I think so far the majority are in favor of B, but we can keep voting. Okay, so this is how we voted. You can comment on the results.
Okay, thank you very much. So the correct answer is B. So just to say 1 or 2 things. So from this scenario, because we are looking at testing from 0 to 2 months, so infant number 2, who was tested at 10 weeks, is already out in the discussion. So we are looking at infant 1 and infant 3. But because we are doing PEPFAR reporting, so infant 1 had sample collected at birth, so that counts. So infant 1 is counted. Infant 2 had sample collected at 6 weeks. That also counts. So the correct answer is 2. However, if you were reporting for MOH, the answer would be different because then we would want a result. So for MOH, 0 to 2 months, we would only be reporting infant number 1. So this is where there is a difference. And I deliberately didn't put that option for 1 infant because I knew that is a source of confusion where PEPFAR is reporting a sample, MOH is reporting a result.
Okay, so we are going to relaunch our third and final poll question, and it reads, a June 2018 HIV exposed cohort has 5 exposed infants. One of the HIV negative mothers who gave birth in June 2018 has tested HIV positive in January 2019. The midwife wants to add this child to the June 2018 cohort, but the MCH in charge wants the child added to the January 2019 cohort. So between the two, who is right? So we have our third polling person. This one is attracting quick responses. That's nice. Okay, the majority think the midwife is right, but others, 22%, still think the MCH in charge is right. Which cohort does this child belong to? Okay, I'm going to end the poll and then we can discuss the results. So 78% think the midwife is right. Comments?
Yeah, thank you very much. So yes, the midwife is right. So the majority have got it right. So as we said in the slides, the cohort is defined by the birth month. So we talked about living space where we go back and add the transients and those who seroconvert. So this child belongs to the June cohort when the child was born in June 2018. So even when we test them in January 2019, we go back to that page and add them because they belong to the June cohort.
So thank you very much for the presentation, Dr. Keith. I think it's been very enlightening. We have discussed PMTCT, where we are, where the gaps are. I think we have seen that we still have a big gap when it comes to PMTCT EID. And you've also told us that we currently don't have a system in place to track all the expected deliveries to see if there's a quarter back for their postnatal visits, for postnatal services, and how that we can actually engage the community health care workers to help us track this mother-baby pair to make sure that we don't lose them. So at this point, I just want to invite any questions or comments from the network. Do we have any questions or comments for the presenter? Let me also take this opportunity to just welcome Kafue General Hospital and Railways Clinic in Kafue. These are the new sites that are logging in for the first time. So Kafue General Hospital and Railway Clinic, welcome. So do we have any questions regarding the presentation? Any comments? Okay. So I think we have a question from, is it Choma? So Choma, you can go ahead with your question.
Thank you, Dr. Kandio. Are you getting me?
Yes, we can get you clear.
Yes, thanks, Dr. Mweebo, for the good presentation. We have understood certain terminologies that we didn't understand at first. Now, I have a question. I just wanted to find out the difference between the newly tested positive and the newly identified positive. I didn't get you well there.
Thank you very much for that question. So, Dr. Keith, you can respond to that.
Thank you very much. There is no difference. So newly tested positive is the same as newly identified positive. So what we were referring to in the presentation is newly initiated. So we have some women who present in ANC, they are already known positives, but they are not on ART. So non-positive, then newly initiated. So they are initiated in MCH when they present for ANC. So that's where we'll have a difference, like we'll have non-positive, newly initiated. Then we have newly tested positive and newly initiated.
Thank you very much. Does that answer your question? Choma General, does that answer your question?
Yes, Dr. Kandio, it does. I think he has clarified.
All right, thank you. I think we also have a question from Mongo Urban. Mongo Urban, go ahead with the question. Mongo Urban, kindly unmute your microphone. Go ahead with your question.
Good afternoon. Precious.
Good afternoon.
Speaking. I would like to find out about the Smart Care patch that has just been updated. If we do have an option B+ register, because I think for easier monitoring in the EFS sites, it would be better if we have an option B+ register that is just fixed so that everybody would easily go through the names, because facilities now have to just pick out names from antenatal registers, from EID registers, just for them to compile an improvised register to use for monitoring.
Thank you very much. You can respond to the question, Dr. Keith?
Yeah, thank you very much for that question. We can get back to you with the specifics once we clarify from Broadridge. Yeah, I actually get your concern. So at a facility where you have a system that is networked and data is being saved in the server, yeah, it's very difficult to get that list of mothers on option B+. However, if you are operating a standalone module in MCH and they are not linked to the server, the report you run in MCH, the ART register in MCH will give you that cohort. So we'll get back to you with a specific, I'm not sure if the current patch has included that. In line with what you have said, we are also asking them to include actually the HIV Exposed Infant Cohort Register, so that it also auto-populates once you are interacting with the exposed infants in an e-first facility.
Thank you, Dr. Keith. We have a question from Chilenje Hospital, and they're saying the major contributing factor to the baby's outcome in HIV-exposed infants is the mother's viral load suppression status or not. So why is it not included in the cascade?
So very good question from Chilenje, and we agree with your observation. So initially when we did the cascade, we had the viral load cascade for pregnant and breastfeeding women, but the presentation was going over the limit in terms of slides. And we see that as a big gap in our programming in PMTCT. As a result, we decided that we check out the viral load cascade and we will do an echo session dedicated to viral load monitoring for pregnant and breastfeeding women.
So thank you. As Dr. Keith has said, we'll probably try and have another session regarding the viral load monitoring cascade. So we'll take one last question from Patty, and then we'll go on to our case presentation. So we just want our case presenter to get ready. So Patty, go ahead. You can unmute your microphone and go ahead with your question.
I'm asking, this is a Livingston Musana Steven, a student nurse for HIV business provider.
Sorry, we can't get you clearly.
My question is, how do you harmonize at the national level the results from PEPFAR and the results from government?
Okay, we are going to ask you to kindly repeat.
Yes, I'm asking from Livingston Nursing School. My question is based on the report which you generate from PEPFAR and the government. How do you harmonize them?
So I think his question is on how you harmonize the report. Okay, we've gotten your question. Thank you.
Yeah, thank you very much. So as you may be aware, the Ministry of Health and PEPFAR have been doing what we call data alignment. So that exercise is still ongoing. What that means is they want indicators we collect for Ministry of Health to be the same as indicators we collect for PEPFAR. So in terms of the indicator you are referring to, PMTCT EID. So the ministry reports a result, whereas PEPFAR reports a sample collected. However, PEPFAR has another indicator, which is PMTCT HI, which is disaggregated for positive or negative, which is where you report a result. And the thinking behind was because we have so much challenges with the EID testing, we wanted to know where the problem is. Are we not collecting samples, or we are collecting samples but results are not coming back to be entered into the file? Once this is addressed, then both indicators will look the same. But we have a way of harmonizing, because the EID testing reported by MOH should be the same number as the PMTCT HI, pose or negative when we combine. I hope that addresses your question. But going forward, there is a process that PEPFAR has started doing where they are harmonizing, aligning indicators.
So thank you very much, all of you, for this very interactive discussion. We are going to go into our case presentation. And our case presenter is Nathan from Kafue Estates Clinic. So Nathan, get ready. Just briefly introduce yourself to the network. Nathan, can you hear us?
Yes, please, I'm hearing you. Is everybody hearing me?
Yes.
Hello? Are you getting me?
Yes, we can get you. So please go ahead with your presentation.
Thank you very much. So my name is Nathan Sinyangwe. I'm a clinical mentor, and I'm presenting from Kafue Estates Clinic. So I'm with a team for Kafue Estates. We're about 21 in attendance. Sorry, we're using a laptop, so the camera is not able to capture everyone in the audience. But we've been joined by the MCH team, we've got the students and also the counselors. So let me go ahead and make a presentation. Next slide, please. The next slide. Hello? May I have the next slide, please? Okay. So the next slide. Hello?
Hello, I think you need to change the slide yourself.
Okay. I'm trying to scroll the slides from here, but I'm unable.
You click on share and so share the page of your slide. You need to click on share. Or there's a share button, there's a small square box with an arrow up. Click on it and say share.
Oh, okay.
Yes. And it will give you options that if you share your screen, and then you'll be able to change the slides and we will see them.
Is it possible to share from that end?
We don't have your presentation. Don't you have the presentation on your laptop?
Okay, let me check.
Okay, Nathan. Nathan, we are going to help you from the hub. We'll share the presentation from the hub.
All right, please do so. Here I'm unable to share.
Okay, all right. So just stop sharing your screen so that we can share from our end.
Oh, all right.
Okay, you can go ahead, Nathan.
Okay, so that is our case. We'll begin with a history. So this is a case of a female who is 34 years old of Kafue Estates and married with 3 children. And then she was diagnosed with HIV and started on ART. That was on the 3rd October 2010 during first ANC visit of her first pregnancy. So she has 3 children. The first child tested HIV positive at the age of 3 and was started on treatment. And then the second child tested HIV negative. And the third child is the one who is currently exposed for HIV. The husband is also HIV positive. And the wife tells us that he is also on treatment, but not sure of the viral load status. We've tried to find out from her if she can be able to bring the husband forward, but she tells us that the husband is very busy, so we're not sure of her viral load status as well, and also whether it's true the husband is on treatment. And so she gave birth to the last child. That was on the 16th of October 2018. The child had a weight of 2.9 kg. The APGAR score was 9/10. And right away, the baby was commenced on the AZT3TC plus nevirapine. And also, sorry, AZT3TC and the nevirapine just, not CTX. Prophylaxis was given for 6 weeks. And then at the end of the prophylaxis, at the end of the 6 weeks, DBS was ordered while the child continued breastfeeding. On physical examination for the mother, on 21st June 2019, she was doing very fine. As you can see there, the BP was 137/76. The temperature was 35.9. The heart rate was 95. And she had a weight of 48 kg. The systems were reviewed and everything looked normal. Then for the baby, the temperature was 35.6. The baby weighed 6.9 kg. And then the baby was 66 centimeters in length and the MOH was 14 centimeters, which are normal parameters. And also the system was checked. All the systems were good, and she continued breastfeeding very well. So this slide is a clinical timeline and the lab results for the mother. So as you can see on the regimen, she was started on TLE. That was in December 2010 when she started treatment, when she was diagnosed HIV positive. But in March 2019, she was changed to second-line treatment. That was AZT3TC and lopinavir. Then on 22nd May, the lopinavir was replaced with the atazanavir. So that is the current regimen that she's taking right now. On the lab results, the HIV tested positive. That was in 2010, and right away she was started on treatment. And these are the recent viral load results that are on our file. So the first one was done in 2017. That was ordered November 23rd. And in December 25th, the results came out. And the viral load was 22,412 copies. Then in 2018, in August, another viral load was ordered. The results came back in November 29th. And the viral load went a bit down. It came down to 16,181. Then in December, another viral load was ordered. And then the results came back after 2 weeks. But as you can see, this time around, the viral load has gone up quite a bit high. That is 66,154. Then CD4, she's got 3 CD4 results on her file. And the highest CD4 is 333. The lowest is 189, which was done in June last year, 2018. And so we've looked at all the CD4 results, but so far she's got about 6 CD4 results. We only picked the 3 recent CD4 results, but so far 333 cells per ml is the highest CD4 count she's had. For RPR, we're not sure. This may have been done as part of focused antenatal care, but the results, we're not so sure. Creatinine, the last recent results, it was 76.1. And before that, so that is only creatinine results we have. But LRT, the results were 28.0 U/L. Next slide, please. So this is also the clinical timeline and monitoring for the child. So the child at birth was started on AZT3TC and was given nevirapine. And then the first DBS was ordered. This was at 6 weeks. That was 27th November 2018. We did not have the results on the first DBS which was done. But at 6 months, the DBS was repeated. The results came back on the 30th March 2019, and the results were negative. Okay, so our questions are as follows. So the first question is, considering the viral load cascade, as we're able to see 22,000, 16,000, and 66,000, for how long should the baby have been given prophylaxis? Remember in the presentation previously, we said the baby was only given prophylaxis for 6 weeks. The second question is, the highest viral load which came back in December, 66,132. The child had already been discontinued. Would it be ideal to continue giving a child AZT3TC and nevirapine, considering that now the mother, the viral load is very high? Then the third question is just a courage to find out if it was indeed a good idea to change the woman to second line treatment. And then this woman was found in general ART. So the question is, where should she have been managed in terms of ART with the child? Is it ART or MCH? And the last question, but which is not part of the case, is anything wrong in giving an exposed infant prophylaxis throughout breastfeeding? Basically, this question comes from the mothers themselves when they want to, but why discontinue giving a child medication when the child is still breastfeeding? So they usually want to find out whether there's anything wrong with giving a child prophylaxis until cessation of breastfeeding. Thank you very much.
Okay, thank you very much, Nathan and the team, for preparing such an interesting case. So we have a 34-year-old woman who was diagnosed with HIV in 2010 during her first antenatal visit. And this woman has been on TLE, had been on TLE from 2010 to somewhere around March this year when second line. But in between, before the switch, from 2017 November up to December 2018, we noticed that she has 3 high viral loads. And the latest, which was done on the 13th of December 2018, was 66,152 copies per mil. So she has 3 children. The first one is also HIV positive on ART. The second one is HIV negative, and now we have this exposed infant who is still breastfeeding. Her current regimen, that's the mother's regimen, is AZT3TC with atazanava. We are told she has a spouse who is also on ART, but the regimen is not known and the viral load status of the spouse is not known. So before we answer the questions, we encourage any comments, clarification from our spokesites and participants. Do you have any questions for Nathan? Mongo Eben, you can go ahead.
Let's take down the questions. We are free to.
Mongo Eben, go ahead with your question.
Yes, I would like to find out from the to that second line regimen when I think there was no indication of them showing that they did enhanced adherence counseling to ascertain the cause of the high viral loads. Considering also the fact that the husband to this woman's status is not known and they're actually not sure. So why did they have to switch her just by them having that result? To say it's a high viral load, let's put her on second line. And also, not a question, but the child, the last child now, the one who is exposed is 9 months. So I think there is need for that child to now be tested with a rapid test so that we can get to know how the child is faring.
Okay, thank you for your question and comments. Before we respond to that, let me just get a question from Lukonga, and then Nathan, you can respond to both questions. So the question from Mongo Urban is, what indication to switch to second line, seeing that EAC had not been done, and we have not been able to establish the viral load status of the spouse and whether or not he's adherent to therapy. So Lukonga, go ahead with your question, and then Nathan will respond.
Okay, I think my question, the first question has been asked by Precious. We really wanted to know the reason why the mother was switched to second line, because we can see that even after being switched to second line, the viral loads are still persistent to be high. So meaning we didn't really solve the issue at that particular point. So the other question is on the baby. We are trying to wonder why the child was put on 6 weeks. When looking at the mother's viral loads have been high, those don't not have a recent viral load. But with those viral loads that we've seen, it shows that the baby was really at high risk, and we managed to put the baby on prophylaxis for 6 weeks. So with a question that you asked that need to be answered, I think first we're supposed to put the child on the 12 weeks, which is the high risk. But with those results of the mother, for me, I would even want the child to continue on prophylaxis since we don't have any latest results on the viral load of the mother. So I think stopping the baby, it's really basically on the viral load of the mother. That's what can really make us stop the prophylaxis. So I think those are the issues that I wanted to raise.
Thank you very much, Lukonga. And we are glad that you have also given parts of the answers regarding one of the questions they asked on the duration of the prophylaxis. So maybe just to clarify on the ART, the mother was switched to AZT3TC lopinavir in March this year. So the viral load, the high viral load, which is 66,852 copies per mil, was received in December. So we don't have the latest viral load after they switched to second line. So Nathan, we're going to give you a chance to respond to the two questions. What was the indication to switching to second line, and why was the baby given prophylaxis for 6 weeks, seeing that already at that time we had a result from 2017 of an unsuppressed viral load? So Nathan, go ahead.
Thank you very much, sir. So those are the very good questions. So I'll start with the first one from Precious. So when the results came, the first viral load results of 22,000, so at that point we didn't switch the woman to second line, but rather she was enrolled into enhanced adherence counseling, of which she was adhering. But when we did the second viral load a year after, that's when we realized that the viral load was still very high. So at that point, we thought that maybe she needs to be changed. And so we looked at also the viral copies themselves, which was 66,000. Because if you check on the viral load cascade, from 22,000, the viral load went down to 16,000. Then in a short while, the viral load again went up very high to 66,000. So at that point, we thought really we needed to change the woman's second line treatment, bearing in mind that she was breastfeeding. Then the second question from Lukonga as to why was a child not given prophylaxis for 12 months, so for 12 weeks. That's what we really, that one I might say that was some kind of an oversight, and really we thought would take back the baby with prophylaxis. But at that point, the child was already discontinued. But if we really had a good check of the file, we agree, yes, Lukonga, the baby should have been given prophylaxis, not 6 weeks, but 12 weeks. So that was some kind of an oversight.
Okay.
Thank you so much.
Two more questions from the participants before we answer the questions that Nathan and the team have. So we have a question from, this is Bill Kabala. What is the BMI of the mother? Have you screened the mother for TB? Is it possible that she has an OI at this point? So Nathan, you could quickly respond to that. And then we'll take one last question from Chadiza District Hospital.
Yes, actually the BMI was checked, it's about 31. And then currently she does not have any OIs, as you were able to see by physical examinations. And also this itself, she does not have any OIs right now.
Okay. So thank you very much. Chadiza, quickly go ahead with your question.
The question that I was asking the team was if they consider this is a woman.
So Chadiza, we can't get you. Let's move closer to the microphone.
Okay, can you hear me?
Yes.
Yes. Okay. My question to the team is: this is the woman who is married to a truck driver, and the husband is also HIV positive and also on treatment. So I wanted to ask if they had considered the cross-infection with regards to the viral load cascade. And the other question that I wanted to ask was, I think it has been answered. The team, from the last question that the team asked, it's clear that they know that the child, when he's still breastfeeding, the child is still exposed, can still get the infection, but they had to give 6 weeks prophylaxis. So I'm sure they have clarified, say it was an oversight.
All right, thank you very much. So Nathan, there's a question there. Chadiza District, kindly mute your microphone. Thank you. So there's a question there. The husband is a driver. Have we considered the possibility of cross-infection? I think Nathan did, try to bring out those concerns when he was presenting the case, but you could go ahead and respond to that. Nathan, are you still with us?
Yes. What was the question?
So the question is, the husband is a driver, so have we considered the possibility of cross-infection, seeing that we have no idea how the husband is performing in terms of ART and viral load?
That I must say we have got no idea, because as I mentioned, we've tried that she brings the husband on board, but it's been very difficult. All the attempts have failed. But once you get hold of the husband, I'm sure I'll be able to listen for that and be able to follow up if there is anything like that.
Okay. So thank you very much. So in the interest of time, I know we have a lot of burning questions, but in the interest of time, I'd like us to go to the questions that Nathan and the team have. So they've asked a number of questions. So Chatonda, you can just share the slide with the questions. So as he's preparing to share the slides with the questions, Nathan, just a quick one. Why haven't we done a viral load? That's a question from Yeta District Hospital. Now that the woman has been on second line since March, why haven't we got the latest viral load? Do you want to say something about that?
The viral load, yes, we're looking into that since she was just changed recently. That was the we're following up that. We've taken note. We're really going to follow up. She's been really put on such a microscopic eye, so we're going to follow that up. We're going to do that.
Okay, so I guess we'll be able to get more info regarding the viral load, how we're supposed to monitor this breastfeeding woman from our subject matter experts. So the first question is, considering the viral load cascade, how long should the baby have been given prophylaxis? Do we think this baby who is exposed, HIV exposed, should continue or should have continued prophylaxis for breastfeeding? I think I'm going to throw this one to Dr. Mweebo. Dr. Mweebo is our pediatrician here at the hub. So Dr. Mweebo, what did you think?
Okay, I think first things first. In this case, they didn't follow the guidelines. It's very clear they didn't follow the guidelines. Number one, 4 weeks before delivery, we should have done viral loads so that we know in which category to put this baby. Okay? And then if you can see, there was a viral load that was done in 2017. So if they had done one a month before delivery of this baby, they would have known where I was standing. So as you classify the baby in high risk, low risk, this one would have been a high risk, of course, and they would have been continued for 4 weeks prophylaxis, while trying to make sure that the mother's viral load is also being suppressed. Okay, now, the issue of mother being managed here is adult physicians. But I know that at the end of the day, what is important is U equals to U. Undetected equals to can't transmit. So here the guidelines are not followed. So we can only classify the baby or give the baby for prophylaxis at least for 12 weeks while waiting for this viral to be suppressed. So the adult physician, what can you do? Make sure we suppress as quickly as possible. So this mother's viral load is undetected. But also it appears there are some issues of adherence here. So they told us that they've tried to engage the husband, it's not coming. But I think the most and biggest problem here is the mother. How do we suppress this viral load so that she's not able to transmit? We can't go beyond 12 weeks per se under the current guidance because these drugs also have toxicity. That's the major issue. Because even when you were giving an environment throughout the entire breastfeeding period, it was only for those mothers who are not on ART. If you're on ART, it was given for a period of time, then you stop. You couldn't continue. If mother was on ART, again, it's a question of when you are not undetected, you can transmit. So the adult physician should help us to make sure that this baby, this mother is has viral which is undetected. So we have to manage the mother. That's the biggest issue. Otherwise, the way it is, I think the guidelines were not followed properly. If they were, I think we would not be in this situation because this mother has been with us for some time.
Okay.
Yeah.
Thank you very much, Dr. Muya. I think these questions are actually linked. Copies per mil. And I guess that now comes to your second question. At the time when the viral load was 66,132 copies per mil, when they received that, the baby was already discontinued on prophylaxis. So the baby only received 6 weeks prophylaxis, which I think the team has agreed might have been an oversight. So now the question is, considering that the child is still breastfeeding, would it be ideal to retain the baby on prophylaxis?
I would still classify this baby as high risk.
High risk.
So we restart and then give for 12 weeks. Or you, the physicians, make sure you're suppressing the mother.
Godfrey, would you like to comment as well?
No, that's correct.
Okay. So since this is linked to breastfeeding, I think the fifth question is there anything wrong in giving an exposed infant prophylaxis throughout breastfeeding? I think there may be instances where the mother may not be ready to start ART, or in this case, mother is not suppressed, or they know they're not suppressed, maybe they've been cancelled, they're not willing to, switch to therapy, maybe second line or be third line. Is there any role for continuing prophylaxis during the breastfeeding period? Dr. Keith, do you have any thoughts on that?
So this is a very interesting question which the sub-TWG that Dr. Muya chairs has been discussing. It was thrown by one of the physicians here who thought, what do people think about? So this is an issue probably that I will throw back to Dr. Muya because we're still having those discussions, but it's a very good question. So there are issues around toxicity that pediatricians talk about. And then, of course, we look at the evidence. From WHO's perspective, from the public health perspective, really, there was no added benefit of extending breastfeeding for life. I mean, extending prophylaxis throughout the breastfeeding period. So studies show that once you work with the mother and the mother is suppressed, then there is no need to continue breastfeeding. So the evidence doesn't show that. So we want to focus our efforts on ensuring the mother is on ART and that is suppressed. But for those Other issues like where the mother has refused, I think the TWG has been discussing and I have missed a few. Maybe Dr. Muya can comment on that.
Okay, so where the mother has refused to take ART, the only evidence we have so far was we can revert back to the option A, where we're giving the therapy throughout the entire breastfeeding period. That we can do. I mean, the evidence is there. We've done it before. Okay, but if the mother is on ARVs herself and she's not suppressing, that's a very difficult question, because now we really have to make sure we keep on counseling this mother. Maybe we can extend it, like we said, maybe for another 12 weeks. We classify them as high risk, give the 3 drugs, but ensuring that the mother, we try as much as possible, make her understand that if she's not suppressed or she's not taking her drugs well, leading to her not being suppressed, she'll transmit. Like Dr. Mweebo has said, evidence so far has shown that the only way is if you take your drugs well, you're well suppressed, then you can transmit. If you are sure she's adherent that there is not well suppressed, then you probably think it's treatment failure, then we change drugs accordingly. Otherwise, going with 3 drugs, mother on ART at the same time, that evidence is not there. But what we know is quite toxicity is our major worry. Yeah. But if the mother has refused completely, which is not in our guidelines, of course, because we expect that everybody was supposed to accept, maybe that unique patient, we can revert back to where we were in option A, where we're giving only therapy for the entire breastfeeding period.
Okay, thank you very much.
Maybe add a small comment.
Yes.
I thought that it would be good for clinical teams out there to kind of, I think, consult before they take certain decisions like this, before the condition of the patient departs significantly from the desired outcome. I think there should be channels for consulting, because this has become a bit of a tricky case.
Okay.
Yeah. Okay. Channels of communication. We encourage. There's a toll-free line, 7040, which is even in our guidelines, where they can call. We discuss. Yeah. So that is open. Usually, people call in, so we discuss and find a way forward on case to case of how to go about it. But what is very clear for me for this particular one, since it's somebody who has been with us from quite a long time before even this current baby, a lot of things would have been done if you follow the guidelines as they are now. So the most important thing actually is to follow the guidelines. If you follow the guidelines with such patients, I think we'll not be in this situation. Okay, there might be times when, of course, things don't work out, but if we follow the guidelines as they are, I think this baby will not have been talking about this story. But of course, we don't know the current viral load. She could have suppressed from that 66,000. Okay. But at the time to 66,000, they have classified the baby as high risk.
Okay.
Yeah.
So thank you very much. Maybe just a follow-up question. Dr. Msangwe can comment on this. So if they did a viral load today, and they can see that their last viral load, they got the results within 5 days, and the mother is suppressed, what would be the way forward in terms of testing this baby? The baby is 9 months old.
So in terms of testing the baby, it's still like follow the guidelines. You need to do the 9-month test. The child is now 9 months old. And depending on the result, because you're considering that the mother may have resuppressed now, which is like 3 months, 3 months from the time she started treatment. I would think that this would be a good time to actually retest the child at 9 months.
Okay. And which test would you recommend? Because I heard from the network, someone of the we do a rapid antibody test.
So now we're looking at the NAT at 9 months. Okay. Yeah, that would be the test to go for.
So Nathan, just to give you more info, now we are looking at doing NAT at 9 months. So just to wind up, we have just 2 more questions. The 4th question is the woman was switched to second line. So was the switch appropriate, or should they have done EAC? And where is this woman supposed to be followed up? Is it in the adult ART clinic, which is a general ART clinic, or MCH? So Dr. Msangwa, you can comment on that one. How do we follow up this pair?
So in terms of the EAC, the switch, whether the switch was correct, it's not very clear, I must say, in the guidelines what we do with pregnant women. But it's prudent because pregnant and breastfeeding women, but it's prudent that we put them on a durable regimen as soon as possible. So in some quarters, it's been proposed that we switch to a second line regimen and also conduct the EAC at the same time. That is because we want the woman to, if they have genuinely failed treatment, you don't have the luxury of time to keep the child on a non-suppressed regimen. So that is not a very clear, it's a gray area in the guidelines, and I think that is something that the technical working group needs to make very clear so that the health workers are clearly guided on how to manage the pregnant women. Your second question was?
Where should this woman be managed? This woman was transferred to the general ART clinic. So should she have been followed up in general ART clinic, or now she needs to go back to MCH?
So the guidance has been that women should be followed up in MCH until the child is discharged at 24 months. That's been the guidance, but I think on the ground, it may be a different scenario on how best they manage that, but that's the recommendation.
Thank you very much for that. Before we summarize, I'd ask Dr. Keith, is there anything else you'd want to add to the discussion so far regarding the case?
Yeah, so thank you very much. So maybe just two comments. Yeah, the first one, as Dr. Muya has said, even for the mother's side, she delivered in October. We don't know when she booked in ANC. So based on the viral load she had in 2017, in May 2018, if she was already pregnant, we know she was already pregnant because she delivered in October. She was due for a viral load because she was then 6 months from the previous viral load. So at the time of booking in ANC, this woman should have been booked for a viral load in May. And then that viral load in May probably would have been high. Then we should have started intervening way before she got to deliver in October. So that was another missed opportunity. Then just to add that, as Dr. Msangwa has said, we encourage that these women be transferred from ART to MCH so that they
which is very important.
Turns out from the
Going back to your questions, how long should the prophylaxis have been given? I think that one has been answered. We needed a viral load within 1 month of anticipated delivery. So at that point, we could have known whether to classify this baby as high risk or low risk. And then secondly, we do not know right now how the mother is doing in terms of her HIV. We don't know if she's virally suppressed. It would be nice to get a viral load on the mother, but we also need to confirm if the baby is infected or the baby is negative. So we've been advised that what we need to do now is a NAT on the baby. And since we don't have the latest viral load, this infant probably needs to be regarded as high risk. And the recommendation has been that we restart the prophylaxis for at least 12 weeks until we get our viral load result back for the mother. In terms of where to manage this woman needs to be transferred back to MCH because we need to follow up the mother-baby pair up to a period of 24 months. Regarding the switch to second line, we've been advised that the technical working group is working on some guidelines. So the switching to second line in this case was appropriate. However, the mother should have been engaged in EAC at the time of the switch as well. So I guess in the next couple of weeks, we are probably going to get more guidance on how we are supposed to manage pregnant and breastfeeding women with an unsuppressed viral load, provided we are sure that we don't have any adherence issues. And we have been reminded that we have the 2018 guidelines that we can refer to when we are stuck, as well as contact with specialists via consultation. So we have the toll-free line, which is 7040. And I think now we actually have our clinical mentors on the ground, and Nathan is one of them. So I'll just encourage all of us to just make sure we get in touch with our mentors when we're stuck, or we dial 7040 and you can get help. Whether it's a pediatric case, maternal case, adult case, you will be able to be linked to a specialist. So I don't know, Nathan, have we addressed your questions, or do you have any more burning questions or areas that haven't been clarified so far?
I think so far most of the questions have been addressed. Unless from the team. Now everything has been taken. I think that so far so good. We'll just do as recommended to follow up on the mother's test for viral load. The child now is at 9 months. We'll do that, and of course we'll be waiting for the guidance, especially on the switch and also the other things that have to be done by the technical working group. Otherwise, so far so good. So we'll start the prophylaxis. I don't know, do we now count 12 weeks from now going forward?
We can't start now.
So maybe Dr. Muya, what would be the best action?
For now, let's get the viral load, because don't know the viral load of the mother. Because they should have suppressed at this time. Because this 66,000 was before they switched to second line. Yeah, December. So we don't know the status now.
Okay.
Yeah.
So we have a clarification there that there's a possibility she has suppressed. So if our turnaround time is good, the advice is let's get the viral load of the mother done.
Okay, all right. Thank you so much.
So thank you very much, all of you, for your active participation. Before we end the meeting, I'll just like to ask Nomsa if there are any announcements to make.
Oh, thank you so much, everyone, for your participation. Like it has already been said, we look forward to your joining in next Monday, and our topic is on differentiated service delivery. So look out for that topic and please join in on time. Thank you.
So thank you, all of you, and to our subject matter experts, we always appreciate your coming. So we end the meeting. See you next week.
Thank you.